Hello students, today we will be studying one of the sexually transmitted diseases called as gonorrhea. Gonorrhea is a Greek word which means flow of seeds. It is attributed to Galen, a scientist in 130 AD who is said to have believed that urethral exudates in male with gonorrhea was semen. In 1879, Neisseria gonorrhoeae was demonstrated in the stained smears of urethral, vaginal and conjunctival exudates, making gonococcus second identified bacteria pathogen which discovered the Bacillus anthracis. This was first cultured in vitro by Leistikow in 1882, and effective antimicrobial therapy in the form of sulfonamides was applied in 1930s for gonorrhea. Thayer Martin formed the medium for the culture in 1962. Risk of infection for a man after single episode of vaginal intercourse with an infected woman is estimated to be 20% and 60 to 80% after fourth exposure. Prevalence of infection in women is 50 to 90%, and Neisseria gonorrhoeae is the causative organism for gonorrhea. It is a gram-negative, non-motile, non-spore forming diplococci. It is present intracellularly in neutrophils. So this is the history as well as characteristics of the Neisseria gonorrhoeae. Pathogenesis. So gonococcal structures which are involved in the pathogenesis of gonorrhea are the different structures like pore, OPA, RMP, pili, lipooligosaccharide, peptidoglycan, iron repressible protein, IgA protease, etc. So these are the different structures or components of the gonococci which are causing the Neisseria gonorrhoeae. So these components of the Neisseria gonorrhoeae are helping in insertion into the host cell membrane, adherence. They are acting as a target for blocking antibodies. They produce resistance to the neutrophils. They act as tissue toxin. They target for bactericidal and chemotactic antibodies. Then they are also involved in the ion uptake from transferring lactoferrin and hemoglobin, and they escape from mucosal immunoglobulin A. So all these are the different components which are helping in the pathogenesis of Neisseria gonorrhoeae. So steps in pathophysiology or pathogenesis. First is adherence. Adherence means attachment. So this is an initial event wherein Neisseria gonorrhoeae adhere to the mucosal cells mediated by the pili, OPA and other surface proteins of Neisseria gonorrhoeae. So these proteins help in the attachment of Neisseria gonorrhoeae to the mucosal cells. Invasion. Organism is then pinocytosed by epithelial cells which transport gonococci from mucosal surface to subepithelial spaces. So invasion means entry into the body, that is organism is taken in the form of pinocytosis, that is cell drinking by epithelial cells, and these gonococci are transferred from the mucosal surface to the subepithelial spaces, that is called as invasion. Simultaneously with the attachment of gonococci to non-ciliated epithelial cells, gonococcal endotoxins also impair the ciliary motility and contributes to the destruction of surrounding ciliary cells. So after attachment, these kind of effects is produced by the gonococcal cells. Then third stage is tissue damage. So here when progressively the gonococci enter into the epithelial cells, there is progressive mucosal cell damage, submucosal invasion which is accompanied by vigorous neutrophil response, submucosal abscess formation, that is accumulation of fluid, exudation of purulent material into the lumen of infected organs. So pus-like conditions are formed into the tissues after the infection with the Neisseria gonorrhoeae. Fourth step is dissemination, that is ability to resist the killing activity of antibodies and complements in normal human serum is closely related to the ability of gonococci to cause bacteremic illness with or without septic arthritis. So Dissemination means here the capability of resistance towards the antibodies is developed in the gonococci, which further increase the illness. So these are the various clinical manifestations which are arising due to the gonococcal infections or from the Neisseria gonorrhoeae. First are the asymptomatic infections which are in urethra, endocervix, rectum and pharynx. Symptomatic infection occurs in the different parts of the genitourinary tract, that is urethritis, inflammation of urethra, cervicitis, that is inflammation of cervix, then conjunctivitis, inflammation of conjunctiva, then pharyngitis, that is inflammation of pharynx, etc. Then local complications are also developed along with this, like salpinginitis, epididymitis, Bartholin abscess, lymphanginitis, penile edema, periurethral abscess and prostatitis. So all these are the inflammation of the different genitourinary organs. First, urethral infection in men. So acute anterior urethritis is most common is in men. Incubation period ranges from 1 to 14 days after the gonococci enters into the urethra. However, major of the men develop symptoms within 2 to 5 days, and there was a case in which 36 of 44 men with uncomplicated gonorrhea in a few studies in which time of exposure could be clearly defined. Predominant symptoms are urethral discharge or dysuria. So there is initial scant and mucoid or mucopurulent in appearance, that is pus-like formation in most of the male urethral exudates, and this is relatively profusing within 24 hours of onset, that is continuing. Dysuria, that is difficulty in urination, usually begins after the onset of discharge. Variable degree of edema and erythema of the urethral meatus, that is urethral cells, is commonly seen, which is due to the gonococcal urethritis, that is inflammation of urethra. So the gonococci cause urethral infection in men. Urogenital infection in women. So there are several sites which are involved. First is endocervical canal, that is the canal of the cervix, urethral area causing urethral colonization. 70 to 90% of infected women are in this category. Infection of Bartholin's gland duct is also common, and this is the incubation period is variable, but usually 10 days it is taking. Most common symptoms which are there in the infected women include increased vaginal discharge, dysuria, difficulty in urination, intermenstrual uterine bleeding and menorrhagia, that is menstrual bleeding. Purulent exudates occasionally must be expressed from urethra or Bartholin's gland duct. Purulent exudate means pus-like exudates. Next, rectal infection. Rectal mucosa is infected in 35 to 50% of women in gonococcal cervicitis, that is inflammation of cervix. Only rectum is involved in 5% of women, 40% in homosexual women, and symptoms range from minimum anal pruritus, that is pus formation, painless mucopurulent discharge, then or scant rectal bleeding is there. Then apart from that, the symptoms such as proctitis and including rectal pain, tenesmus and constipation. So all these are the conditions associated with the pain and inflammation in the rectum. External infection shows erythema and abnormal discharge. On anoscopy, that is the observation of anal canal, it shows mucoid or purulent exudates, erythema, edema, friability or other inflammatory mucosal changes. Next is pharynx. Pharyngeal infection is also involved. 3 to 7% of heterosexual men and 10 to 20% of heterosexual women and 10 to 25% of homosexually active active men are involved. Acute pharyngitis or tonsillitis is associated with fever, cervical lymphadenopathy. More than 90% cases are asymptomatic. Infection to other sites. So gonococci also cause the infection to other sites of the body. These include the conjunctiva also. So primary cutaneous infection is there. Then apart from that, localized ulceration of genitals, that is genitourinary organs, perineum, proximal lower extremities or fingers. Complicated gonococcal infections. So local complications in men, epididymitis, that is inflammation of epididymis, which is present in 20% of cases, and most of the causes of acute epididymis in patient is under age 35 are the trachomatis and Neisseria gonorrhoeae. So Clostridium trachomatis and Neisseria gonorrhoeae are causing epididymitis. Penile lymphanginitis, that is the inflammation of lymph node of the penis. So penile edema, which is called as bull-headed clap. Post-inflammatory urethral strictures are formed. Periurethral abscesses are also formed. Local complications in women. So these are the complications which are most common complication of gonorrhea. So 10 to 20% of acute gonococcal infections are formed. Bartholin glands abscess, systemic complications. So here disseminated gonococcal infections more common in female. Then the classical skin lesions are there. Gonococcal dermatitis is there. Macules, papules, pustules, bullae or rachomyces are the other kind of infections which are present. And arthritis dermatitis syndrome is also there in the acute gonorrhea. So these complications are located at the distal portion of the extremities. Gonococcal endocarditis and meningitis are occurring in 1 to 3% with the gonococcal infection. Diagnostic, coming on to the diagnostic process. So gram stain is used to stain the smears. Microscopic examination of stain smear show gram negative diplococci in polymorphonuclear leukocytes. Culture, antibiotic containing selective media, that is Thayer-Martin media, is used for diagnostic sensitivities of 80 to 95% of the specimens. Small pinpoint colonies can be seen, 90% within the 12 hours and 100% within the 6 hours of sample collection. Oxidase reaction. This is to identify gonococci from mixed culture. Then a drop of tetramethyl phenylene diamine hydrochloride is poured over the suspected colonies, which turn pink and then dark blue. Non-culture diagnostic techniques wherein culturing is not done. So nucleic acid amplification tests, that is NATS test, polymerase reaction test, PCR, transcription mediated amplification, TMA, other nucleic acid amplification technology also. These are more sensitive than the cultures for gonorrhea diagnosis, and specificities are nearly high as for the culture. Immunological and biochemical detection of gonococcal antigens, including surface protein, endotoxins, oxidase or other enzymes, can also be investigated, but they are less promising or effective than nucleic acid detection. Fluorescein conjugated antibodies, these are used to give positive results 24 hours before conventional culture technique. Serological diagnosis, that is the serum is used for diagnosis purpose. So complement fixation, immunoprecipitation, bacterial lysis, immunofluorescence, hemagglutinin, latex agglutination, enzyme linked immunosorbents and other techniques are used for the diagnosis. Sensitivities of about 70% and specificities of about 80% are shown. Rapid carbohydrate utilization test, RCUT test. It is used to detect beta-lactamase production by Neisseria species. Detected by change in the color of phenol red, pH indicator from red to yellow. Treatment. So, uncomplicated gonococcal infection of cervix, urethra or rectum, and uncomplicated gonococcal treatment of pharynx. The treatment given for these two conditions are as follows. For uncomplicated gonococcal infection of cervix, urethra and rectum, cefixime, ceftriaxone, ciprofloxacin, ofloxacin, levofloxacin can be given. For uncomplicated gonococcal infection of pharynx, ceftriaxone, ciprofloxacin can be given. Then for chlamydial infection, azithromycin can be given and doxycycline can be given in both the conditions. Then in disseminated gonococcal infection, following drugs can be given: ceftriaxone, cefotoxim, ciprofloxacin, ofloxacin, levofloxacin, cefixime, etc. And for gonococcal conjunctivitis, ceftriaxone single dose can be given. Gonococcal meningitis, ceftriaxone can be given every 12 hours. Gonococcal endocarditis, ceftriaxone is a drug of choice. Even in ophthalmia neonatrum, ceftriaxone can be given. Follow-up. So treatment: patients with the antibiotic regimen, CDC regimen, need not follow up to confirm their cure, but the patient with persisting symptoms may be tested for antimicrobial susceptibility and other cause and tested accordingly. So this is all about the pathophysiology, etiology, then signs and symptoms, clinical features, treatment of the gonococci or Neisseria gonorrhoeae infection, that is gonorrhea. Thank you.